Welcome to POCUS Geek. My name is Jared Marks, and in this series of videos we're going to review how to obtain vascular access with ultrasound guidance. In an effort to keep them hopefully short, we're going to do this in a two-part series. One is going to be picking a target vein, and the second part will be how to obtain the access. I think many people are doing ultrasound guidance to obtain vascular access, and sometimes I see novice users of ultrasound not necessarily using ultrasound to their advantage. I think it gives them an idea where the target vessel is, but not necessarily increasing their effectiveness in getting access quickly. So hopefully some of the techniques here, whether you're just starting out or have been doing it a while, will help you to better pick vessels to go after, and also how to obtain access in a quick and effective manner. So typically, I talk about binary questions that we use with ultrasound. In this case, we don't have binary questions. What we do have are some objectives that we're going to review. And we're going to do the first three here in this first video and the last two in the second. And that is essentially we want to be able to pick the right vessel, use the right catheter, and then make sure we're putting it in the right type of vessel. And then in part two, we're going to talk about how to set up the room so that you can obtain access quickly and be able to verify that you're in the correct spot. So there's a rule called Paget's law, which happens to do with, how quick a flow can go through a tube, essentially. And the important part of this, I'm not sure none of us remember this, or I didn't, but pressure times pi times your radius to the fourth power divided by 8 with the viscosity and the length determines how quickly a flow of a fluid can go through a tube. So the important here is that the radius affects how quickly flow would go, and then also the length. And so those two factors are what we're going to control with the catheter that we're using. Now, to put this into perspective, a lot of times I see residents say, well, we need to put in a central line to get to resuscitate, to give them volume, and we don't. We can be using peripheral vessels for this, and we can even see here that like a normal 20 gauge, about a 1 1/4 inch catheter, or 33 millimeters, is going to give us a higher flow rate than if we put in a triple lumen central venous catheter that's typically 20 centimeters. And so we can even see with gravity flow that the rate's twice that of the triple lumen, and even if we put a pressure bag on it, it still beats it out of how quickly per minute we can put in fluids. So when we pick a catheter, we ideally want to go as large a bore as we can for the vein. We want a shorter catheter just because that will increase the rate at which we can do it. We do have to pick the right length of catheter to hit the vein and keep it in the vein. I typically like to keep about 2 centimeters in the vein. The deeper I go, I like that to be a little longer so it doesn't get accidentally pulled out if they have a lot of adipose tissue. You want to pick a proximal vein if you can, because that will have a higher flow rate. And then you can do the lower extremities, but if you can, stick to the upper extremities because they'll have a little bit better flow rate. So typically, people that I'm going to be looking with ultrasound means that the nurses have tried and have not been able to obtain access without ultrasound guidance. Now, we at my institution have some nurses that are excellent at it and can do it well with ultrasound guidance, and that's great. And then we have, some that cannot. And so typically, if somebody's looked peripherally and can't find anything, then we're going to look with ultrasound. And I don't typically look distal to the elbow, only because most of the time the nurses can palpate this or see those well. And if they can't, say maybe it's a darker tone the individual has, or maybe they're really volume down, we can't palpate those veins, and so we're going to be turning to ultrasound. And when we start doing that, I don't find it that useful to look in the distal forearm simply because those veins become so collapsible and they're hard to find. So I usually start looking at the median cubital vein, and that's typically where I start. And then we'll go through what each one of these looks like here just briefly. So this is our vein here. Let me get rid of that one and actually do veins in blue. So this is our vein. We've got our artery over here. That's our brachial artery before it comes down. And we're going to be able to see that relationship here. So let's go ahead and go to the next slide. So we can tell that the vein's compressible and the artery's not, and that's important for us. Let's go to the next vessel. So we're going to look at the cephalic vein. Now this one is not as obvious or not always there. So we can see it in some individuals. You see it a lot in weightlifters, but people, the general population, when I'm looking for this, I'll still look here, but it's sometimes very hard to find simply because it's very superficial and collapsible. But we can see here that vein is very superficial, and we can just see that it's going to be a collapsible vein, and that we can tell right there that we've got a good target vessel to go for. Alright, so we've got our basilic. Now I'm going to point out a couple things here, and we're going to see it again on the next one, but we've got a vein here, and on the still image it's hard to tell, but this is likely our vein. Here's our artery, and then we have a nerve here. We've got another little nerve right there and right there, and then this is most likely another vein right here. Oops, wrong color. This is most likely another, wouldn't change colors for me. There's another vein right there. And so we're going to watch this video, and what we're going to focus on is just the basilic. We will see the deep brachials again here, and we'll see them flipped on a different extremity. So we can see those veins collapsing. We can see that in this image, we would prefer to go after the basilic, which is right here, because it's away from all these other structures. But if that's not visible, we may have to go after a basilic, a deep brachial, and that gets a little more fishy working around those nerves in that artery. But let's see an example of maybe one of those we would pick. Okay, so here we can see in this patient, so this arm is a different arm or extremity, and so we would look over in here for a basilic, and we don't see anything. There's no basilic to obtain access in, and so instead we're now going to look here at the vein. Here's our artery, and once again our nerves are not quite as obvious. This is a big one, and then we should have a little nerve right there, and there's probably one in this spot, but it's hard to see on this image at least. So let's see what that vein's going to be nice and collapsible, and that's what we're going to go after in this patient. Now we have to be very careful because it's sitting right next to their artery and their nerves, and this is why it becomes especially important to know where your needle tip is. Now if we can't find that and we need to start looking for central access, we've gotten this high, we can start to look at the subclavian vein. And a lot of people don't go after the subclavian vein with ultrasound guidance. I think if you got a nice probe and you're good at this, I think it's okay to do. I find it very useful. Some individuals struggle with it. It's a little bit harder to do with your guidance because it's hard because of the clavicle being in the way. But what we're going to see here is we've got our clavicle up here. This is our vein, and then this is our artery. And the hard part about this is it's not always collapsible, so it's a little difficult to tell that it's there. But we can see here that can be collapsible. Now, this video in particular, and we'll talk about this more when we do verification too, is we can see there's some hyperechoic material within the vein, and that's actually a saline flush being pushed on the patient, and we're verifying that we've obtained access. So this particular patient, if I remember right, was a severely volume depleted DKA patient that we had to obtain access, and we're up in the superior basilic, and so we were verifying that we hit the right vessel before giving other medicines through it. And then lastly, now some people are doing supraclavicular. I've not had as much success with that simply because the probes we have are pretty big and they seem to take up the space and I can't get access to them as well. A subclavian, internal jugular is my next best choice. And we're going to see that here of having our IJ right here, and this is our our carotid, and then we do have some thyroid out in here, and then our trachea over in here. So let's go ahead and see that this is a nice vessel that we can go after also. Now, if you get to this point, or maybe you choose not to, maybe you want to look for a different vessel, you can look at the legs. And there's two that I typically look at in the legs, and that's going to be a femoral if I need a central line and I can't get to the head of the bed to do a line and I need one quickly, then I'll do that. Some people still do that without ultrasound guidance, and if you're doing any of these, that, you know, kudos to you. I feel it's safer, and so I use ultrasound when I can. And I'll also look at the saphenous as a peripheral vein. So if we look at the femoral, if any of you reviewed the DVT ultrasound, this is the same view we're going to obtain. And in this, we happen to be looking at a right leg. And what we see is right here is our artery, and then our veins next to it, and that's our target vessel. Our nerve will be out in here. We don't see it well in this image. So if we look there, nice and collapsible, good vein to go after. Now, I'll typically, I did these a little back, just working from the head down now, but I will look at the saphenous to place a peripheral if I don't need to necessarily obtain central access. And what we can see here is a saphenous vein is actually very good. You're going to place it on the inner lower leg, and that's going to allow you to visualize the saphenous vein. Some people have great saphenous veins and others do not. But we can see here this vein being isolated out here all by itself and is a great target. There's another small superficial vein right there, but it would be quite a bit more difficult to hit. So we can see that vein's nice and compressible for us, and that we could go after that. Now, I mentioned in all of them, why do we want to make sure it's compressible? We want to make sure it's compressible, one, so that we know it's a vein. And you can collapse arteries, so be careful with this. You can collapse arteries simply because you put too much pressure, and maybe their volume down. So you got to take it with a grain of salt, make sure your anatomy matches what it should be. But the arteries are going to require quite a bit of pressure. Now, part two is if they have a clot in that vessel, say it's either a DVT or a superficial thrombophlebitis, you don't want to be dislodging that clot or trying to place a catheter into it. And sometimes even, especially when I get up into the central vessels of the neck, I will scan the entire area and make sure I don't see a clot, and I'll pick my best spot to go. So we'll see here, this is another example of a basilic vein. We can see it's nice and compressible. There's no other structures around it. Would be a great target vessel for us. We can see over in this area that there's deep brachial, and those are still some options, but this is nice and isolated, so that would be our ideal option. I prefer that you use, that my learners, residents, myself, and others I work with use compressibility to determine your vessel. You can use Doppler, but I think there's some pitfalls. I think one, novice people forget that Doppler doesn't tell you which type of vessel it is. Blue does not mean vein. Red does not mean artery. It all has to do with flow, and if you actually, when we do this, a lot of the time we're perpendicular, so we don't get to appreciate the flow as well as we should. So just as a reminder, if you are angled such that the blood flow is away from you, then you're going to see blue on your screen. Whereas if it's coming towards you, you're going to see red. Now, if it's, and this is just color Doppler, and if you're perpendicular, you may not see anything because the flow is neither to or from your probe. And the same thing is true if you use pulse wave Doppler. So if you use pulse wave Doppler, you may see this type of pattern if you're hitting the artery and it's pulse wave, but if you aren't hitting it well, you may not see anything, or even a vein may be confusing. So if you're using pulse wave, this is an example of what you may see, but you got to take it with a grain of salt. Here is also, if you have it coming towards you, it would be red on color wave. On pulse wave, you may see spikes if it's arterial. If it's a vein, it would just kind of give you a nice constant flow, and it actually may look like this. Now, if you're perpendicular to the vein like this, and that's what we most often are when we're doing this test. This is what a vein can look like, but you can also have an artery look like this because it can't detect the blood, the blood cells actually coming to or from the probe. And so this is where it's really important that you use compressibility, I think, to determine, and also know the anatomy, determine which vessel you're going after. Now, when we go to approach this, what we want to do is think of the angle we're going to use. So if you're picking a really deep vein, the angle may be such that you can't approach that vein quickly enough to leave enough catheter in there, and you're going to be worried about the catheter being dislodged and having extravasation. And also you may not be able to see as well. So when we think about it, if we go very steep with the needle, an ultrasound beam comes in and hits it, but the problem is majority of it, just due to ultrasound physics, are deflected away from the probe, and you get a very weak signal back, so you may not appreciate that needle and where the tip is. Now on the converse, you can go flat, you can go at a lower degree, and it's great because you get a lot of image back, which is great for using ultrasound, but the problem becomes is sometimes you run out of catheter in order to hit that vein. So the ideal is typically about 45 degrees that you're going to go down. That way you don't lose a bunch of signal. You can see your catheter or your needle quite well and be able to determine, and also you can kind of calculate the length you're going to go. So then we can talk about depth. Now depth, the more superficial you can go, the better, but typically, getting down past a couple centimeters gets more difficult, and I would try to pick the most superficial one you can. Now we can, before we even start, consider how far we're going to need to go in, and this is part of the advantage of using the 45 degrees, because we can think of Pythagorean theorem, and essentially, whatever our depth is going to be the same amount of length that we're going to travel if we go at 45 degrees, and then we can essentially know close to what our amount of catheter we're going to need to get that far. So for instance, if we have a vein that's a half a centimeter deep, then we're going to have to travel about 7 millimeters of catheter is going to be just in the subcutaneous tissue before we even hit the vessel. So picking a catheter that's only a centimeter and a half would not be ideal. You would typically want to go at least with probably a 33 millimeter catheter, or what's about 1.25 inches to get there. And that's kind of what this chart goes through with. There's not really any good guidelines on how much catheter length needs to be in the vessel, but you can see here clearly as the vein gets deeper, we want more catheter length into the vessel, because here we've got this length and they're going to go about 3 to 4 centimeters inside the vessel. So just remember, you want to have plenty of catheter inside the vessel. Now lastly, to talk about here is how do we pick our vein. So I talked about it a little earlier, in that you want to pick a vein that is isolated if you can without other structures near it, simply because there's less risk to injuring other structures. Now that's not always possible, and if it's not, then what you want to make sure of is when you pick your vessel that you pick a vessel with a free wall. So the free wall would be that if we're going to obtain access, we want to come in and be directed so that if we go through the posterior wall, we go through the vein and we don't hit other structures. Whereas this type of structure where the vein sits right on top of the artery would not be ideal, because we may come through the vein and actually puncture into the artery and not realize it and leave our catheter there. And now we've created a situation where a fistula can develop, and we don't want to be doing that. So even if we have a structure like this where they're overlying, which we'll see a lot of times with our IJ, we can still go after that particular vessel. We just want to make sure we go after the free wall. So our approach would want to be over here instead of over here. We don't want to do that. I hope that you found that topic useful. If you have questions about it or other related point-of-care ultrasound questions, feel free to email me at pocusgeek@gmail.com or comment below.
Also, subscribe to this channel to get updates on this topic or other point-of-care ultrasound related subjects.